Good morning, everybody. I see everybody's joining. It's almost 10 o'clock. It feels like a weekend. It's so quiet because of lockdown. I'll give everybody a minute or so to get on. For those of you wondering where we're starting with the beginning of Unit 4, and we're going to have a couple of different things we're going to talk about. Good morning. Okay. So like I said, this is the beginning of Unit 4. Good morning, good morning. I'm seeing messages. Thank you all. Okay. What I want to do is I want to talk to you all about, and like I said, I hope you all are well and everything is good. It's very quiet. Oh, gosh. So I know, let's go ahead and get started. Today, what I really want to talk to you about is we're going to kind of shift gears a little bit, but then we're going to come back to health. We're going to come back to a little bit of COVID information. Okay. But I wanted to start talking by talking about demographic factors. If you see, this says health policy and global implications. So it's a good way, and it's a good thing I thought we'd look at now, is talking about age. Okay. Um, when we talk about age, it's another demographic factor. And as it says down here in my big line, I say demographics based on age. So we know certain conditions and stuff. We know certain conditions can impact on whether we get a disease. Are you young? Are you more at risk for one thing versus being older? We know that a lot of our NCDs, right? When we talk about NCDs like cardiovascular disease and diabetes, typically these were diseases that you got later in life. If we're talking about respiratory infections, uh, a lot of times those were things we saw in pediatrics and children. So we see different diseases based on the demographic factor of age. And we're going to come back and we're going to talk about deaths with COVID a little bit later in this morning as we finish up, I hope. And we know that death rates are different and who's more impacted on COVID. So this is something that happens whether we're talking infectious diseases, being communicable or non-communicable NCDs. Okay. When we talk about it, and if you think back, it's been a while since we've looked at our older slides from Unit 3, regular Unit 3. We talk about age composition or structure. And if you remember, there was a term that was called dependency. And the dependency rate really was looking at children and the elderly. So a lot of times we talk about the larger size of a population being between the working ages. And working ages, we typically go between 15 and 60. For a lot of people, it's getting a little bit longer and things along those lines. But once we retire, we then become dependent, and it may be on family. In the United States, it may be through assisted living and retirement communities, but we're not actually the same tax revenue base. We're living off retirement. We're living off money we've saved. Children, before they become of age to work, they're dependent on their parents. We're dependent on our parents to feed them, clothe them, provide for them, school, educate them. So that's why it's called a dependency ratio. Okay. And that also changes how we look at different health policies. There are a couple of things that I thought would be interesting that you should know. And if you look over here, this is just talking about males versus females over time. I don't know if you knew, but I hope if you didn't, you find this interesting. Did you know that actually there are more male babies born than females? and stuff. But what we find out is that as life goes on, we end up with more females than males. Okay, and this is just what it's saying. What's interesting, males experience a higher mortality rate at all age ranges. Whether it's infant, child, there are more of you born as guys, but you have a higher mortality rate at every single age. Okay, age range. Um, During childhood, males outnumber females. And like I said, as we get older, it slowly dissipates. And by the time you get into your 60s and 70s, we have more females than males. Okay? There are a couple of different ways we can talk about gender distribution. Okay? We can talk about it from a sex composition, which is where I put the two numbers together. In other words, I say number of males to number of females. We have 5-to-1 ratio. That's a sex composition. When I talk about males are 5 times more likely to develop disease X versus to every 2 females. Okay, but for every 5 males that get this disease, we get 2 females that get this disease. That is a sex composition. Okay, so we put the numbers side by side. We can also do it a different way, and we can do a sex ratio. And the same way we have a formula for prevalence, incidence, case mortality, or case fatality, any of our mortality rates, we have a sex ratio. And we put always the number of males on top and the number of females on bottom. It's just easy. If we always use that formula, males on top, females on bottom, we can calculate the sex ratio. Why do we do that? Because remember, as we grow older, we're going to get more females. So it's going to go from a whole number to a fraction, typically. Now, I think this will help explain some of what I'm talking about. I'm going to blow this up, and I'm going to let you see this graph. This graph is actually really cool. It is the birth and death rates in Jordan. Okay, so, and it's going over time, and it projects out to 2050. So if we look here, and you all should be able to see, I think if I do it any bigger, it won't. Here we go. Yeah, I got to come down just a little bit to fit my screen. Sorry, guys. Okay, if you look at this, we go from the 1950s, so it's going over 100 years, and it's births and deaths per 1,000 people. Notice that, again, we're using a population number, so we're using per 1,000. Notice that in the 1950s and 60s and 70s, which is probably your parents' age of when they were born, we are looking at very high birth rate, very high birth rates. Birth rates is the blue line on top. Death rates is the pink line. But notice what else we have at that time. We have also a really high death rate. So while we're having lots of babies born, we also have lots of people dying. So a lot of times that ratio is kind of balancing each other out. And we're going to talk about something, and you're going to learn why this happens on next Monday. Okay? But what we follow is the birth rate then starts to decline. As we look here by the 1990s, and you all were born around year 2000, we start to get to about 30 per 1,000, okay? And notice, okay, so when you all were born just above 32, 30 in this time frame. And now if we come down, what we've got is it's actually a little bit higher, okay, but it's about 2.97, okay? And they're showing birth rates still dropping. We expect this happens as societies change, because what we find is that more babies live. So if you have more people living, they don't have as many children, and it's expensive. It's much more expensive to live in Amman and have 7 children, have to feed them, educate them, clothe them, send them to schools, than it is to have 2 children. Okay? And remember, we talk about that ratio of 2 being the replacement value. In other words, 2 parents, 2 children each child replaces one parent kind of in our population flow. So what we're seeing is this happens. Now notice this comes down much slower than the death rate. And here we've got the death rate. It was really high, and all of a sudden we get to the 70s, and it really drops fast, and then it just kind of stays the same. If you notice, really, and we're projecting that it will go up a little bit, and I would love to know when we get there what would happen. Now, let's see. I'm seeing a quick question. They should be at the same age group, like the example. They should be at age 18, both genders. Yeah, we're going to start comparing age groups. In other words, we're going to compare, let's say, children 1 to 5, and we're going to compare them for males and females. And this is typically what we do. We typically break them up in little 5-year increments, and we break them up and we compare groups. So what we do know is, if I come back to, and I'm coming back to look at this, is let's come to right now. We're about 2020. Notice the birth rate again is still dropping, okay? And we expect that to happen. This is what happens when societies become what we call westernized. In other words, you move into cities, you don't need children to work in the fields, children are expensive, and parents start, and you use birth control, and parents start family planning, and they have fewer children, okay? Now, what's interesting is the birth rate doesn't come down as quickly as the death rate did. So notice up here, while it came down, it's still really, really high up in the 80s and 90s. So we have this big population boom because less people are dying, but we still have lots more people being born. And what we're going to do next week is we're going to look at how this looks then on a population pyramid, okay? And I'm going to give you a little homework this week. I'm going to give you a link to a 5-minute video to watch, okay? Because I'm not real sure how the video will play through live. So I'm going to give you a little homework, 5-minute video on that will introduce class for next week. Now, if I come back over here, let me see if I can show you this. Okay, so typically, what do we know? We know more males are born than females. We know that males die more at every age. There are differential patterns of migration for males and females. In other words, migration. Remember, we're talking about people that move away. We can talk about people that move to Jordan to get jobs, people from Jordan that move to other parts of Gizmo. You're just being a brat. Stop. Stop. Thank you, Gizmo. Okay, so you can have people, Gizmo, stop it. I said, stop. Thank you. Ugh. I know you don't want to stop. I know you just want to bark at the door. Hey, look at me. Stop. Thank you. Sorry, guys. Gizmo. Hello. Wait 1 second. I apologize. Stop. Stop. I'm going to say, hello. Back over. Thank you. I apologize. Gizmo is deciding to talk this morning, so my apologies. And what we know is, so people will move away. People may move from Jordan to the U.S. Some of you all will move to other countries for residency and to practice medicine at the beginning. So we see a lot of migration when work starts. People move to other parts of the world, typically for work patterns. Women may move because they marry somebody from another country and stuff. So we will see different migration rates at different times. And we're going to learn how to recognize that. But like I said, from the very beginning, the surprise factor is typically there are about 105, 106 boys born to every girl, or every 100 girls. Now, let me go ahead and bring this back into size and go on to the next. These should be numbers, at least the first 3 should be numbers you already recognize. I do see a question that was published that's really good. Let me publish this. Why is the death rate going up after 2020? Let me go back on slides and let me address that. That's a great question. Okay. When the death rate starts going up here or after 2020, what we start to see is Jordan is starting to get an older population. Do you remember when I talked about the number of life expectancy? And we talk about life expectancy has been growing. When you start to have a longer life expectancy, people live longer, and therefore, and you go, but that doesn't explain the death rate. We see more chronic disease. We start to see more cancers. We start to see what? More cardiovascular disease. All of these things start to then, as we become older, having an impact on a higher death rate because our society is older. Okay, so that was a great question. Let me see. Does the birth rate decrease because of economics and industrial increase, which makes life expensive and even harder to get? Absolutely. The next question is about the crude death rate. Why is it increases again, even though the healthcare will probably increase in a large percentage? Let me see, what does that say? Why is the crude death rate increases again? Like I said, that's because we end up with more people with chronic diseases. That's really what's happening, and the infrastructure is not designed to take care of it as well. So those are great questions. Let's see. Will it stay the same with COVID? I'm not sure the death rates. We're going to go to COVID later in class. Let's not look at death rates. The death rate in COVID the rate is going up because of COVID. Yes, the death rate is going up because of COVID, and that's where we're going to finish class today. So I'm not going to quite get there yet, but you're on the right track. Now, these first three numbers should look familiar. They're the same numbers you saw in Unit 3. And this is that age dependency thing. And these are related specifically to Jordan. And it is important to know this. If you remember back in the beginning, we had that one little slide, life expectancy. Again, this is the average of life expectancy. This is for males and females combined. It was about 73 years. For you all, and that was if you were born around at a certain, that's based on people right now. If we come to babies born today in Jordan, their life expectancy is longer. Okay, remember, it's based on when you were born. What I really want to draw your attention to is that dependency ratio. We've got about 35% that are dependency in the childhood range, and right now only about 5% are dependent for being elderly. What we expect and why we see those death rates come up is as your population ages and you have less babies, we're going to have this dependency ratio will go down, and this dependency ratio of the elderly we expect will continue to go up. Okay, here's the bad part. When we're talking about elderly dependency, we are talking about more serious health conditions and more health care costs that the government needs to budget for. Okay, with children, a lot of it is immunizations, so we get through it very quickly. Females die more than males or less? Omar, no, males die more than females at every age range. Okay, males die more at every age range. Doctor, why are we suffering from chronic diseases more than communicable? Remember when we did this back at the very beginning, I showed you 3 different slides and we looked at the trend of changes in diseases. And from 1900, we died more from communicable diseases. By the time we got to 2000, we're dying more from NCDs. By the time we got to 2020, it is definitely NCDs. Okay, there's only really one normal statistic, which is respiratory infections, which are in the top 10 cause of death. The exception is going to be this year because we know COVID will also go into the top 10 causes of death globally. So that's why are we suffering more? Because we're living longer and we don't live as healthy of lifestyles, and as we live longer, we see more disease. We've also gotten better at treating communicable diseases. Most of them you don't recognize because we have vaccines for them, so we prevent them. Other ones we have good treatment for, so we're able to stop you from dying from it. So that's why we're seeing more suffering from NCDs than we do communicable. Okay. No, guys, all the numbers here do say that males die more than females. Okay. There are more males born. That's just a global average. Okay. Now, let's see. Next question. I've got 3 questions I'll answer, and then I'm going to continue forward. What question you please? The birth rate for males higher than females, but on the previous we took females higher for 1.5 than males. I don't know where you're getting this 1.5. So I've got to tell you, we've got 100. It says 105 males to every 100 females. Okay, that is the birth rate globally. Okay, Laith, you asked, why don't we hear about other chronic disease deaths these days? All of them are from COVID. Well, I got news for you. We still have people dying of chronic diseases. This is absolutely the case. But here's the thing. What are we focused on? Our healthcare system is overwhelmed, and we're going to have people that die from other NCDs, and it doesn't get recorded that way because we have our healthcare systems overwhelmed by treating people. Remember, if they can't get to the hospital, there's no autopsy, they die. It's just coded. We give it the best reason we can. So a lot of this is impacted. People don't stop dying from other things because COVID is here. It's just that COVID is taking up, for lack of a better all the oxygen in the room. Okay. One of you asked, let's see, I was curious of men dying earlier. Actually, most of it has to do, some of it may be chromosomal or genetic. A lot of it has to do with men tend to be risk takers at all stages of life more so. Little boys will accidentally do things and take risks that will hurt them. Because they're out playing and running around as little kids, they get exposed to other diseases that can sometimes kill them more likely. As we get older and we get into the young adulthood age, we know men drive differently than women, and their fatality rate from motor vehicle accidents is higher. Being out in the workforce, workplace and occupational injuries. So these are all reasons, if you notice, a lot of them being cultural in different parts of the world. So that answers the same question, the specific reason why more males die than females. Okay, a couple of you are asking that same question, so that answers that. Well, and Mayor, you say this year, I think the rate of communicable diseases will increase rapidly due to COVID. Like I said, it will be in it doesn't change other communicable diseases. It just means we're going to have 2 in the top 10. We're going to have our typical respiratory diseases, and which they categorize as 1, and we're going to have a separate line for COVID. So yes, but the other 8 leading causes of death are still all NCDs by the time we finish 2020. Now, let me go on. Doctor, I think the ratio of people over 60 will decrease more. Yes, Match, you said, Doctor, after COVID pandemic, I think the ratio of people over 60 will decrease more. Am I right? Yes, and we're going to look specifically at some of those numbers at the end when we look at the COVID deaths. Absolutely. Also, you are stating that the high elderly dependency ratio is more dangerous than a high child dependency ratio. Correct. I'm only stating that because it is more costly. When we do health statistics on cost of treatment, what we find is that people will spend 90% of their healthcare costs they spend over a lifetime are in the last 10 years of their life. Let me say that again. It's not something to memorize, but it's something I just want to make clear. What we find is that of all the money you spend over lifetime for your health care, about 90% of it comes in the last 10 years of your life. Vaccines, we're typically, when you're young, you're healthy. You maybe get a prescription. You go to the doctor every year, you get your shots. You have a regular checkup, but you don't have a lot of typically, and remember, this is typically, we're talking about average, not the individual child that gets cancer. We're not talking about the individual child that has something traumatic happen. But when we put all the numbers together, children are basically healthy. We vaccinate them so they stay healthy. Vaccinations don't cost a whole lot. Some of them only cost pennies on a dollar. So that keeps them from getting sick. We can't vaccinate away cardiovascular disease. We can't vaccinate away diabetes. We can't vaccinate lung cancer. So it definitely costs more. Okay. So yes, and Farah, you said so the dependency ratio for children is going down, correct? Because you all are having less children, so there will be, that number will get smaller, and we're going to see that on a population pyramid next week. And the elderly, as you live longer, we expect that to be more of the population. And that also is what we call a health transition as we move forward in the class. So let's see. I see other questions. Does population density play a part in death rates? Absolutely. Population density can play a part in death rates. That is what we are seeing. Actually, remember in the last couple of days when we looked at the different rates of death rates of COVID, and they were always higher in the big cities because it was a communicable disease. In a big city, it's easier to spread something. That's the same reason why we see higher rates of COVID in Amman than we do in the other cities in Jordan. It's the heaviest and the densest one. The same way Paris, London, New York, big cities are the metropolis. So yes, population density does play a part in this. How do the population of children, which is 35, make up the economic burden, make an economic burden for the country? We have to educate them. You have to feed them. They're not providing taxes. They're not making income. They're not providing any revenue source to the government whatsoever. All they do is actually take revenue. So that's how children are dependent. They're not making income. If you're not making income, you don't have a tax base. If the government is not getting taxes, they don't have money. So that comes back in, that goes to past that explanation. It then goes to Dr. Iman's doorstep, so she can go further than that. But it's just, from my perspective, it's very simple. When we look at a policy perspective, children aren't paying taxes. Children aren't contributing to society, typically in the sense that we need to cover healthcare cost. Okay. So that was an interesting and good question I saw. Let's see. I'm going to go ahead. Hold on. Doctor, is having a low percentage of elderly people better, or does it show that a population has poor health care? Ooh, Matthew, what a question. Let me repeat that again, because I was reading it to myself aloud, but I didn't say it slow enough. Is having a low percentage of the elderly people better, or does it show the said population has poor health care? It could be both. Oh, what a good question. Depending on the countries, if we are talking what they consider as undeveloped or stage 1 and 2 models, where we have a large population still being born and they have lacked to really good health care, we definitely, it says more about they're going to die early because of lack of access to care. Um, the other thing is it could be that you actually have, it can also be something catastrophic. In other words, war or a typhoon, a hurricane, um, a natural event, an earthquake can change it so it kills out a certain age range and it also comes up. But typically, that's what we, in the old models, when we talk about developing countries, the reason why we don't have a high pyramid and they don't live longer is typically their lack of access to quality care. Excellent question. Okay. Um, Sama, you asked incest ratio, why are females on the bottom? Just because that's the way they've done it. I don't have a better answer to you than that, but we set up that rule. It's one of the few times I can say this is the rule. Males on top, females on bottom. Okay, when we do the ratio for calculating it. That's just, there's not a better answer than that is what it is. Okay, we're going to talk about technology. A couple of you said, what about technology? Does technology? Absolutely, having better access. In the United States, we talk about having excellent access to emergency care. If you are critically ill from a let's say you have a motor vehicle accident, you have a heart attack, you have a stroke, you are going to survive more likely in the United States than you are in certain other places of the world. Here's the problem. We're good at critical care. We're not good at access to care. Okay. And if you don't have access to the technology, then you can't use it, obviously. If you don't have access to it, it doesn't change your health care. Can other people that aren't Jordanian have health insurance? Yes, we'll talk about that later in the semester and stuff. So let me come back. And I'm going to stop questions right now because I do want to come back and I want you to look at this. If you notice, there are a couple of new statistics that come down here that kind of are getting to the other questions I'm seeing. Okay, when we look at Jordan's population, what's interesting is Jordan's population, you were on one pattern and one trend for Jordanians. And you all are such a gracious country. You took in refugees from Iraq in the early 2000s, and then in this past decade, around 2011, when the Syrian war started, 10 and 11, um, you all took in more than 1.2 million Syrians. Okay, the refugees have impacted greatly on your population and your demographics because you were taking in more mothers and more children again. So you have a widening that has actually happened as a result of this that even has made your young population even bigger. Okay. When we look at some things, it is important to talk about health insurance. Health insurance, Jordan has adopted a model right now that is closer to a United States model, which says not everybody gets health insurance. It is not everybody has equal access to all care. Now, are they trying to move in that direction? Yes. And I will talk about the fact that if you are, example, if you are a Syrian refugee that does not live in a refugee camp, in other words, you came from Syria and you have an apartment and you live somewhere in Irbid, Amman, wherever, you can buy into the Jordanian government health services. It's very affordable. It was about 150 JD per adult, and it cost a year, and it was costing 50 JD a year for every child. Notice the difference in cost because, again, children's illnesses, they can afford to cover them and protect them. It's much easier for me to give you health insurance, give you your vaccines, than it is to wait and treat you when you're sick. Okay? Depending on where we look and what profiles. So again, this is not a number to memorize. It is a number to understand. It fluctuates depending on our source. 55% of the population, which is over half, and about 2/3 of Jordanians are covered by some kind of health insurance. That means that 1/3 isn't, and we still have others that are, notice 55% of the population, we have almost half the population that has no type of insurance, or maybe they have a private insurance from somewhere else. But we do have a problem with coverage, and we don't have the universal access to care. What is interesting is your cost of seeking treatment is much lower than other places in the world, but also your income and your salaries are much lower. So it's relative. You know, for me as a person from the United States, if I want to go have an appointment with my doctor just for a checkup, it's several $100s. Okay. A normal checkup, $300 to $500. And you go, oh my gosh, that sounds like a lot of money. Well, my insurance is going to pay part of that, but I'm going to be asked to pay part of it as well. So my insurance may pay $300 and I pay $200 of it. Okay. It is relative to income. It is relative. And remember, the United States is the only what we consider developed country that does not offer universal care. Now, what I want you to know, and where we're going to go next week, I'm going to shift gears a second, is this is kind of where we're going to stop. We are going to, at least for this set of slides, is I want you to, again, notice that we're going to look at diagrams, and we're going to start looking at a population pyramid next week. And again, we typically divide them into those three groups. So we're looking at those that are dependent on the young side, those between 0 children. We're looking at the working population, and we're looking at the elderly. Now, that being said, I want us to go, and very quickly, with age and gender, I want us to look at the rates happening with COVID. Okay? I'm going to hopefully stop sharing that screen. Lovely. And we're going to come back to this screen. Yay! At least my screens are working today. It's so hard when technology does not work with you. So what we have here, this is from if you can see up here, it's from 3B. And this is what I had asked you all to look at before class. When we finished class on Monday and we're having the technical difficulties, this was the slide I wanted to show you. What you see here is you are seeing the death rates based on age groups from COVID. Now, if I blow up the screen, and I'm going to blow it up so we can look at different ones at different times, okay? What I can come over here, and this little small blue one is talking about everybody, okay? Let me blow it up a little bit bigger and come down again and come over. What you can see is this was all deaths. And now, guys, these are not Jordan's numbers. These are US numbers because we don't get these pretty graphs out of Jordan, okay? But I just want to show you this. This was February when COVID started, and this runs all the way to the end of October, okay? February, March, April, May, June, July, August, okay, September. Okay, so it's September. Sorry, I lied by a month. Now, what we want to do is when we look here, this black line is the average number of expected deaths. Our general mortality rate. How do we get that? We look at the last 4 or 5 years. How many people died on average every month in the United States for just total? We're not looking at any type of cases. We're just wanting to know our basic crude mortality rate. So this is this bottom line, the solid line. It says, well, statistically, you know, remember, we're running an average. So let's give ourselves a little wiggle room and say that anything within this little range of the dotted line would still be within normal distribution, okay? What they then did is they said, okay, let's look at how many deaths we've had total over this time. And what we start to see is notice that after COVID had February, we're right on track. March, we're still right normal, okay? March is when COVID started to spread to the US. Now, remember, we're seeing death rates here in Jordan go up right now. They're going up now because it takes time. You have to have people get sick, they have to get really sick, and then they die. You don't just get the disease and die. It's not like a heart attack where it just stops. Okay? So by the time we get to April, now we're starting to see, and this is what they're showing. This pale blue line here is showing how many deaths in the United States we started having. This is all cause. So this pale blue line, all of a sudden we start to see our death rates go way, way up. Okay? And notice that then, and that's where we started to see people die in New York. Okay? Then it starts to come down. Then it starts to go back up again. What we did is we counted the number of cases of COVID every month. And we said, okay, let's just count the COVID deaths and see how much this pushes us up. This is the difference of deaths we have had from other diseases that are not COVID related. Okay? And it's still higher than normal. So that question that got asked to me before, are we seeing people die from other things as well? Yes. And what we know is we're not catching all the different types of death. Okay. So we start to see, and what we will see eventually in Jordan as the numbers come through. Yesterday, there were, I think, close to 100 or over 100 deaths for the first time for a day. Okay. That's expected. Remember, we're looking at different rates. So we come over here. Now that's everybody. Now what they then did is we started to say, okay, let's look at it based on age range, our demographic ages, and let's see if there's a difference. Because if there's a difference, what groups do we need to be targeting best about risk of death versus risk of disease? Again, this is a health policy. So we looked, the gray line is the average of what we would expect. And what we did is, again, this is just percentages. This is not real, this is not the actual numbers, the percentage. Notice there's not a whole lot of difference going on in the beginning. But as summer came along and young adults, remember, we locked down really quick, and then we start sending kids back to school, out to play, do other things. And for the first time, young adults are really getting exposed to COVID. Death rate starts to go up. Okay? Then we say, oh, no, we're going to lock down. And what we start to find is that we are getting better at treating it, and that young people, while they're not dying as much, the death rate starts to go down below average from the COVID. So something else is going on. What's interesting, and you go, oh my gosh, well, why is the whole death rate going down? Well, if you start doing less risky behaviors and less active things, in the sense of fatalities related to motor, you're not out driving around all night. In the United States, you're not drinking and driving, you're not texting and driving. We start to see death rates because for this age group, the most likely cause of death is some type of injury. So we start to see the death rates go down as lifestyle behaviors start to change, not because of the COVID. Now, let me scroll down here and scroll over, and let's look at our middle-aged adults, okay, or young adults, 25 to 44. And again, what do we see? Notice here, though, all of a sudden, the death rates, the mortality rate goes way above average. March, April, May, June. These are people that are still working. These are people that are not social distancing. These are people in contact. So we look at the percentages of death rates, and they've gone way up in this group because they think, I still have to go out, and the risk is I'm not going to die, so I'm going to keep going out and doing my job. Now, you're going, oh my gosh, Dr. Heather, how much are you going to show us? I skipped a couple of the other age groups, and I decided then to go to the very last age group. Okay, whoops. Bring that down. And what you see here is what we've got is the elderly group. Notice here our percentages are even higher. Okay, what did we see? And this is exactly when you asked about long-term population density, and when we see elderly people, we are dying at this time compared to the normal average. We're seeing 40-50% increase in deaths at this time. Can we attribute most of these to probably COVID related? Absolutely. So let me minimize back down, and now you can see all three screens together. And that's exactly what it's starting to show us, is notice that when we talk about demographics, it doesn't affect everybody the same. Where are we higher risk? Once you pass the 25 to 40s, and when we get to the elderly, for very different reasons. Now, let's just look at your age population, because I do want you to know, while you're less likely to be hospitalized, if you unfortunately are a young adult that does need to go to the hospital, it is 21% of those do need intensive care. Of that 21%, 10% needed ventilators. And when we look at young adults that die, it's not zero risk. We still have, and this is from the Journal of the American Medical JAMA, American Medical Association, okay? Almost 3% of young adults do die from COVID. So your risk is low, but your risk is there. And I think this is, when we talk about behaviors, this is exactly what we're talking about all the time. You're weighing that pro and con. You go, okay, my risk is about 3%, or my risk is 1%. I'm not going to bother worrying about it. So we get into problems with this because people don't perceive the risk. But what we know is that you still have this risk. Remember, the other thing we don't know when we talk about COVID and demographics is what's going to happen long term to you. We see very different things. So that being said, I want to go ahead. Demographics, I just want to show you some other demographic variables we can talk about with COVID. We can talk about schools. We could talk about race. Here they're talking specifically about comparisons of stress among healthcare work or essential workers between Blacks and Hispanics. We can talk about, can we use NCDs as a demographic factor? Absolutely, so we can compare. And this would be something I would find really interesting, is I would be very interested to know, once we get the real data coming in for COVID in Jordan, I'd like to know how many of them were smokers. Does that make sense? And of those smokers, how many smokers had higher risk complications? I think this would be a really interesting concept to look at. So I would be looking at predominantly, and we could definitely would need to consider shisha when we talk about females and stuff. So I would think that would be interesting to look at. So there are different demographic factors we can be looking at all the time to explain things. We could look at health inequalities, and this gets to the SDGs, the Sustainable Development Goals, which we're going to talk, which is where we talk about the WHO and those goals. Okay, the vaccine, we're still waiting. Okay, and this is just, it doesn't end the problem instantly. There have been, like I said, over the last 2 days, and we've seen the comments, there's been great fronts and great news about this Pfizer drug, okay? But it may take time. It's definitely going to take a lot of logistics to get it dispensed. It is 2 vaccines. It is not one. You have to have one and then the other one about a month at the end of, so about a month apart for the full requirement. The biggest thing is the shipping and the temperature holding, because nobody has facilities designed to hold a drug at this temperature because it's totally new and different. And we had good news yesterday. I think the trial of the antibodies that were given to President Trump has now been approved, at least in the United States, as on an emergency basis. It's no longer, it's in study, but the FDA approved that for emergency treatment. So we've got different things, and this just talks about this. When they look at the numbers and effectiveness, we don't have time in this class. I wish we did. but there are two numbers that they specifically look at, and those are called NNT and NNH, number needed to harm and number needed to treat. And they do this with every single drug we're looking at right now. As we go through phase 3, these are the numbers they are using, besides sensitivity, specificity. What we are looking at, well, those are really more with the testing. Okay, what they are looking at here is how many people, if we give the vaccine to so many people, how many people, that 90% effective, that's the number needed to treat. Number needed to harm is how many people get bad side effects from it and stuff. And are we talking about deaths, or are we talking about just a little pain and redness and swelling at the injection site? So they do very specific statistics called number needed to treat and number needed to harm that help them figure out whether a vaccine is effective and worth the risk. From the Lancet article, I did want to take a minute, and this is where we will kind of stop. Actually, I'll finish this because I know I just have 2 more slides. So guys, that will get us through all of the 3s, and we'll come and start on population pyramids next week. Notice again the 10 priorities: non-pharmaceutical interventions, timely and consistent data, science-based policy. When we come to non-pharmaceutical interventions, what are we talking about? We're talking about masks. We're talking about hand washing. We're talking about physical distancing. All the things you are sharing with your friends and everybody else. Okay? The last couple things I just put in here, and it's something to think about as we start to give up our privacy with PCR tests on phones and freedoms and tracking events. Is this a good thing long term? While it may help you know if you were exposed to COVID, does it give the governments too much access and other people to our information? For those of you that haven't watched it, it's not from my class, but I would encourage you watch it just as a life event. The Social Dilemma is a 1.5-hour video on Netflix that was a documentary done by various people working from what can I say, Silicon Valley, from the big tech companies, from Google, from Facebook, from all of these. I encourage you to watch this. It will scare you. Okay, it's called Social Dilemma. It's a documentary. It's on Netflix. It came out a couple weeks ago. If you haven't had the chance, while you're on lockdown, besides watching my 5-minute video that I'm going to send to you as homework, go check it out. The last slide we've already done, and don't worry about, because we've been talking about these all the time. So, that being said, let me come back. Okay. Share. Hold on. That being said, I see lots of questions still. I can't probably take the time. I know you all have other classes to answer them. I will look at them. Can other people that aren't Jordanian have health insurance? Like I said, yes, we do have that. Let me see. The males and females we've covered. Can other people that aren't Jordanian? Okay, already answered that. Guys, when you ask the same question a couple times, it doesn't. Can you explain us the last point, some Jordanian numbers in the slide? I don't know what. Okay. Yes. But elderly don't pay their own health care through their pension. Children can't pay for the vaccines or checkups. Lena, you're asking about dependency. Elderly are no longer a tax revenue. Some will have insurance that covers them. In the United States, we actually are taking out money. It's one of the few entitlements we have. It's called Medicare and Medicaid. Medicare is for people that have no money, or no, Medicaid is for people that have no money, which is indigent care. Medicare is for those over 65, and it's entitlement program. what happens is all through our lives, we pay into this tax system in the United States. And it says that then once we're over 65, we get certain types of care and coverage provided. It by no means covers most or all the medical cost. So they're no longer being a tax base, and they're actually pulling from the tax revenue. That's why we call it dependency, because they're not contributing to the same level. Okay. Let's see. I'm not going to have time, like I said, probably to do this. How do the population of children, which is 35%, make up the economic burden of the country? Again, like I said, they make an economic burden because we have to care for them. We have to feed them. We have to educate them. All of those things cost money, whether you're educating them privately, which would mean that what? You're educating them through your own income, or if you're educating in the public school, it means it's taxes, and we pay taxes as a citizen. You pay taxes as a resident here. You pay taxes. That money goes to pay for the public school educations and the salaries that have to go there. So any child, if you're not making money and giving money to the government, you are dependent, okay, is the best thing I can say. What I want to do is, I know we need to stop. It's 10:55. I apologize for the questions I haven't gotten to. Hopefully you can go back and review, and it will answer most of those. I thank you for attending today. Please, as my last reminder, most of you probably on here saw that I posted, we still had a few, we had more than 2/3 of you have already responded to the tobacco and vaping survey. If you haven't, please do. It will be available until Friday, and then we will take it down, and over the weekend I will post some results and let you all see how the class responded, the demographics, like we've done before with other surveys. The other thing is, I'm going to post this link. Like I said, it's a 5-minute video on population pyramids. It's what we are going to be talking about on Monday, and it is the rest of Unit 4. So you know how to prepare, and it will really help you. It's a great 5-minute audio video of the things I'm going to be covering in the slides as we go forward. And we're going to look at how Jordan's population has changed from the 1970s up until now, which age ranges are more affected, males and females, and we're going to talk about the impact it has on healthcare. So I wish you all a very lovely weekend. I wish you a very safe lockdown, and that everybody gets along and is happy, and you have a quiet space when your family drives you crazy. Have a lovely weekend.